let me just start off with, the question that I think you've addressed it multiple times, but, one issue that comes up and a reason why many of our colleagues just, sort of say, well, that RCT, says one thing, but not in my hands. The classic statement, which is, in my hands, I have found this, and there are many nuances to this. So, the classic expertise-based design. And I think Stuart Proper has written a little bit on this, and he's commented on this. But the issue of, well, there is going to be different expertise, and so how does a study generalize the, sort of the different technical aspects of a study or the different nuances? And maybe that's why we see some of those differences in the evaluation of some of these treatments. But wonder if you have any thoughts on that.
No, I do. That's like a fantastic question. There's two answers to it. The short answer is when people say, like the surgeon who spoke to me about tennis elbow surgery. And he said, those trials are no good. Those surgeons don't know how to do it. I know in my hands, it works really well. And so my short answer to that is, then you need to do a trial. You need to show me, because I don't believe you until you actually show me some evidence. So that's the easy answer. But the longer answer is that there are criticisms, genuine criticisms of RCTs. And I think some of the things that we're doing with RCTs is making them more generalizable by embedding them into routine practice. And so to give you the example that we just used, we randomized whole hospitals across the country to use either aspirin or Clexane for all of their patients as a departmental standard of care. And then after a couple of hundred patients, they swapped over and used the other one. So this is how they would use it in practice. It's not some artificial trial situation where I've taken fit people aged between sort of 40 and 50 with no comorbidities and applied the test to them. We've just done it to everybody, literally everybody. It was, revisions, fractures, whatever. So you can do trials that are more generalizable. You can always criticize RCTs. There's no perfect RCT, but it will have, in general, it will have less bias than other forms of analysis.
I go back, Ian, to a mentor of mine, and I suspect known to many who are interested in evidence-based practice, Gordon Guyatt. And Gordon Guyatt, has been a strong, as is David Sackett, have been a strong proponents of the randomized clinical trial. When you evaluate it, just as you did, a very small fraction of randomized trials in orthopedics actually are considered low risk of bias. And you made that point very clearly. And that leaves everyone saying, well, what do we do in that situation? And then, someone will quote, and Gordon has said it as well, which is, well, evidence-based medicine is the use of the best available evidence. So what in a situation when someone says, well, I'd love to have a randomized trial. I'm an evidence-based practitioner, but at this point, the best available evidence I have is not an RCT. Maybe it's a case series or something to that effect. I want to move forward. I don't want to have an evidence paralysis where I can no longer use, my own judgment and my own intuition, the values of my patient, and have this interaction. What do you say to that type of individual who, in my mind, genuinely is concerned? They want to see the work. They're actually thoughtful, but they're at this point and they're genuinely trying to figure out, how do I move forward when I know that the majority of the evidence is not ideal?
As long as they understand, people need to recognize their own biases. We need to know that we overestimate what we do.
Yeah.
And if we're relying on a case series for something, then it's, I would say, look very suspiciously at that case series, because nearly every time that case series is written by the guy who made the procedure. And, it's, you've really got to be a little bit skeptical. And you need better evidence. It doesn't have to come from an RCT, but some kind of comparative evidence. Comparing it in a fair way to something else. And the best answer is if that surgeon can do an RCT, continue doing the procedure, but do it as part of an RCT.
But got it. Yeah, no, that makes a lot of sense to me, actually. Yeah, totally makes sense.
Just get better evidence. And the other thing is, that's something I come across a real lot. And I was wrote an article in the newspaper the other day, and I got into trouble from the shoulder surgeons. And they kept coming at me about subacromial decompression. And they said, but this trial, this one trial, and I've just shown you there's 15 trials on subacromial decompression, none of which, show that it works in the short term. And they said, we don't like this one trial because some of the surgeons didn't do many cases and they, whatever. And I said, okay, take that trial out of it. The other 14 trials showed the same thing. There's no trials that actually show this helps. And they go, yeah, but this trial was bad. So there's this false thinking that if I can find a fault in the RCT, I can then assume that the complete opposite is true without any evidence. So
no, I can see that. And if you look back at, for example, I think some here would be familiar with the rapid shift in treatment of the clavicle fracture, right? It went from a historic non-operative treatment. Mike McKee, over a decade ago now, did a trial with the Canadian Orthopaedic Trauma Society, in which they said, if you fix the clavicle fracture and aggressively mobilize, you have a much better outcome. We also, at the same time, saw trials done on the Achilles tendon ruptures, in which they found that actually, non-operative treatment does just as well as operative treatment, and we should be a bit more, careful about, rushing to operation in this patient for all people. And the funny thing is, the immediacy of switch to people going from non-operative to operative, like the popularity of surgical fixation went right up, and Achilles tendon non-operative treatment didn't really come up. It was so there's an internal wire to say, if you can help me operate more, and the evidence will support that, people will jump on board. If you've used the argument of the of knee arthroscopy, you look at knee arthroscopies after those trials came out, they didn't really change. I think the indications switched around a bit, and what they said they were doing. I say they, the proverbial they, as people are out there to scan the system. I don't think, and you and I are not saying that. I'm saying that surgeons genuinely believe helping patients, and you want to help your patients. So under that sort of thing, I find it very interesting. So when you look at the highest impact journals aren't usually like the New England Journal of Medicine. If you look back at the last decade of trials in surgery they've published, I would imagine that 90% of those trials in surgery would suggest surgery doesn't work. It doesn't seem to be that the other way around, where a surgery that works is getting published in the New England Journal of Medicine. New England Journal of Medicine is particularly interested in trying to understand high quality trials in which they are showing it doesn't benefit. And then so the bias is, well, they'll only take it because it's negative, because it's newsworthy. It's newsworthy. They're trying to take down the orthopedic, I'll say in this case, the orthopedic field. There is this real sense that it's us against them.
People are out to get the New England Journal. It doesn't make any sense for two reasons, because the trials they publish are high quality trials. And I've just shown you that 85% of all the trials in orthopedic surgery show that it's not better than not operating. New England Journal is no better than any other journal. It just reflects the reality out there.
I wonder, Stuart, I know you've been pretty active on the chat here. Did you want to come on screen if you happen to be near your camera by chance and maybe share a few of your thoughts? I think you've got a lot of great points here. I've tried to address most of them, but if not, we can keep going here. And while he's thinking of, great.
Look, first thing I've got to say is that it's a fantastic topic to present, because really we aren't researchers, we aren't clinically orientated in the research department. We see a patient, we say, how can I help that patient with the skills that I have? And sometimes you forget that some of the skills that you have are actually how to treat that patient without an operation, or even how to discuss the operation so that the patient can decide what is best for that patient. But I guess the biggest problem I have with relying solely on research is that every research paper has a different criteria for recruiting patients, for deciding who goes in and who goes out, for the classic with DVT, studies is how do you tell whether a patient's got a DVT? So there's so many factors involved in every study that it's really, really hard to compare one with another. In fact, it's impossible. You can't actually do that with any great legitimacy. You can make assumptions and saying, that study was a good study and that study was a good study, therefore I can refer to both, but they don't actually measure the same thing in the same patients with the same surgeons. And that's where I think evidence-based medicine isn't simply about reading an article and saying that article says we shouldn't be doing knee replacements in people. It's about using the information that's in that article to make up your own mind about how to help the patient. The patient has to stay at the centre of all this. And that's why there's a bit of a theme that runs through my questions there. But I guess that the biggest problem we have is that with evidence-based medicine, it's almost taken over to the point where we rely on what that person's told us rather than actually assessing the information ourselves for the patients that we treat.
Yeah, I think, well, one of your problems is you've said it's difficult to compare one study to another, but it's still, that doesn't mean we can't apply the results of a study. We don't have to compare it to another study. If there's only one study out there, we have to look at how closely that approximates to the patients that we treat. And for the DVT study that we're talking about, these are all the patients having joint replacement in Australia. So that applies to my practice. You said different outcomes. Well, we chose symptomatic VTE and death because we asked the patients, what's important to you? And they said, we don't care if it's on a scan. We care if we get symptoms from it or if we die. And so the results of that, I think, will be very applicable. You can't just say you can't apply any study to anything because my patient's different. I mean, you need evidence for it. And if your patient is different, you can't assume that what you're going to do works. You need some evidence for it. Because it sounds a little bit like you're saying, well, there's a problem with that study, therefore I'll keep operating because I think that what I'm doing works.
Yeah. I'd almost say the opposite. I'd say you have to take into account every study, but take into account those studies in relation to the patients and the outcomes and the endpoints that they've assessed. For example, I think the arthroscopy study is a fantastic study because the actual improvements were in patient symptomatology in the 5 years of follow-up. So that even though they ended up having the same end result of a knee replacement, the Cochrane study that was done, I think Rochelle Bookbinder quoted in one of your papers, that study was done with the endpoint being knee replacement. It didn't speak anything of the 5 years in between the surgery and the knee replacement. And the actual data from some of those studies showed, well, patients actually liked being more pain-free for 3 or 4 years, even if it meant having a knee replacement at year 5. And that's why I think you must read all of the study before you say, this person has said this, therefore I must do that.
Oh, sure.
And I think it's just as important as using your own nous rather than, let's say, reading the Bible and saying you're not allowed to do this, that, or the other.
Our own nous is biased. Surgeons
absolutely, and that's why you need to recognise that and take that into account. And I think that's exactly the point I'm making, is that you don't want to be totally reliant on somebody else telling you what to do, but you've got to be able to reflect upon it and say, well, how can I use this information to help my practice with this patient?
Yeah, I think what I'm hearing is, you're both basically aligning on that principle that, EBM begins and ends with the patient. I think we both agree on that. And I think you're both aligning on the fact that, if you're going to, you shouldn't absolutely be dependent on someone else, on someone else's interpretation of information. But that also puts power in the hands of you to say, the individual to say, I need to understand the information I'm looking at. simply reading a conclusion that seems to manage, on any study design probably isn't the ideal approach. So when we say look at all the evidence, I agree. Most of us can't, right? There's just too much information to look at. But I do think, in many ways, when you have lots and lots of studies, I think Ian, you had suggested this a couple of times, which is we can't, quote, cherry pick the study result that aligns with our own personal perception without looking at the quality of the information that's being presented. So I do think we have to be a little bit more careful about when we say the word all, because first of all, it's impossible to look at everything. For the individual practicing surgeon, it's hard. But I wonder, I think you and Stuart are actually aligning. I don't see this as a really big difference.
Agree. You've got to look at the whole study, and it's difficult. A lot of surgeons don't have good, training in critical appraisal and things like that. I'm just looking through some of these other comments, which I'd love to answer, but I've got like whole lectures I could give. The ethics, I don't see this raised much anymore, but you've raised it. How do you ethically compare a joint replacement to placebo? I don't think you can scientifically compare a joint replacement to placebo because you can't blind the patients, because the patients will know if they've had a joint replacement or not. So I think for a joint replacement, scientifically, you can't do it. Ethically, I have no problem. We're doing 2 placebo studies now. And that's not an issue at all, because the alternative is to not find out. And patients love it, and we're doing one on spine surgery. And the spine surgeons were a little bit hesitant at first, and they can't believe it. They said these patients, the fact that they are contributing to the evidence that will help other patients is, giving them, such a boost, they love it. And the other question is, isn't big data, registries replacing RCTs, massive numbers, stuff like that? That's a very commonly quoted thing. So I thought I'd address that one as well. And in the audience here, I'm going to give a plug to John Ferry. He's one of my PhD students. And he's drafting a paper looking at this sort of RCT versus observational evidence. And I'm also, one of my research areas of interest at the moment is causal inference from observational data. So yes, many times you can, but it's like anything. There's no, one answer. And once you learn a little bit more about big data, you find out how damn messy it is.
Well, you see the world, what's happened now. So I think we grew up in the age of everything is evidence-based, and we, when everyone was an evidence-based practitioner, and then when you'd ask them for their definition, there was just as many definitions of what it meant to be an evidence-based practitioner as there were definitions. That was one. Now we've gotten into, I believe, this real push on machine learning, AI, and we're using big data and AI algorithms, and really they're just repackaging for the most part, right, the regression analyses of old school, so to speak. But I do, when you talk to anybody who is truly an expert, many of us purport that we know machine learning, and most of us are not experts. 99% of people are not experts. We talk about it, but that 1% say the fundamental challenge with machine learning is nothing to do with all the algorithms. It's everything to do with we do not have clean enough data sets and data sets that we can analyze. So we talk about using hospital administration data sets and doing all these things, but they're actually very messy. So you hit the nail on the head. At the end of the day, quality will impact the quality coming out of it. I suspect you probably have lots and lots of insights on that. That could easily be the topic of another hour with us.
Another one. I've just next week I'm handing in my dissertation. I'm just finishing a master's in data science.
Yeah, there you go. There you go.
So I'm just doing a dissertation on causal inference using observational data. So
excellent.
It's a look. I love it, but one thing I've learned is that it's not this panacea that's going to solve everything. But yeah, look, it has a place. It has a place.
Listen, we have just come to the end of a very stimulating hour. Great presentation as per usual, Ian. And again, thank you to those who put some questions up, and for those who stayed and attended for the full period of time. Did you have any closing statements, Ian? I know you've said a lot, but is there anything you want to emphasize in your closing statement? The floor is yours, and we will bid everyone adjourn after that.
Yeah, no, look, just thanks for having me. But look, if the evidence isn't there, I think it's the responsibility of the proponent, in other words, the surgeon, to generate that evidence if it isn't there. And we're lazy if we sit around waiting for someone else to do it for us. It's really the onus is on us to be generating this evidence.
On that note, I thank you all for attending another exceptional World Tour virtually coming to you from Australia. Everybody have a wonderful rest of your day or evening. Thanks again.
See you all.
Yeah,
Thanks.
bye-bye. Bye-bye.